What's up, everyone? Welcome back to the Weekly Shot, where I break down the latest in obesity medicine so you can actually understand what it means for your health. Today, we're tackling one of the most common questions I get asked, and that is, do I have to be on this medication for the rest of my life? A brand new study just dropped in the Lancet. It was published on May 12th of this year, and it gives us the clearest answer yet. It's called SURMOUNT-MAINTAIN. And honestly, the results are fascinating, a little sobering, and actually give patients some real options to talk about with their doctors. Let's get into it. So, to understand why the study matters, we need to rewind a little bit. Back in 2024, we got the results of SURMOUNT 4. Here's what happened in that trial. Participants spent 36 weeks losing weight on tirzepatide. That's the drug in Zepbound and Mounjaro. And then researchers then split them into two groups. Half stayed on tirzepatide, half got switched to a placebo, meaning they were essentially taken off of the drug without knowing it. What happened to the placebo group, you might ask? They regained the weight significantly. We're talking about a meaningful reversal of everything they'd worked for, and not just the numbers on the scale. Their blood pressure crept back up. Their blood sugar worsened. Their triglycerides came back. The cardiometabolic benefits they had gained essentially started unwinding. That study sent a pretty clear message. Stopping tirzepatide, or any GLP-1 for that matter, leads to weight gain. Full stop. But here's what Surmont 4 couldn't answer. What if you don't fully stop? What if you just lower the dose? That's exactly what SURMOUNT-MAINTAIN was designed to find out. Here's the setup. 441 adults with obesity spent 60 weeks, that's over a year, on tirzepatide at their maximum tolerated dose, either 10 milligrams or 15 milligrams weekly. Most of them reached a weight loss plateau by the end of that period, which is important because it means they'd gotten the bulk of what the medication could give them at that dose. Then at week 60, they were randomly split into three distinct groups. Group 1 stayed on their full dose, either 10 milligrams or 15 milligrams. Group 2 had their dose dropped down to 5 milligrams. And Group 3, they were switched to placebo. And then everyone was followed for another 52 weeks. So in total, we're looking at a 112-week trial over 2 years. That's meaningful data. Now, one other thing worth noting, this trial had a really patient-centered design element built in. Starting at week 84, if anyone had regained more than 50% of their lost weight, they were offered rescue tirzepatide. The researchers wanted to make sure nobody was put through serious harm just for the sake of the data. Now, keep that detail in mind. It becomes very telling. Before we get into the results, I need to highlight something that I think is the most important detail in this entire study, and it's one that most people will completely gloss over. Every single participant in every single group throughout the entire 112 weeks of this trial received ongoing lifestyle intervention. We're talking professional dietary counseling, physical activity guidance. This wasn't a group of people who stopped trying when they stopped the medication. They kept working with dietitians and nutrition professionals the entire time. I want you to really let that sink in because here's the prevailing belief out in the world right now. If you go on one of these medications, you need to use that time to build better habits. Change your relationship with food. Start exercising so that when you come off the medication, or if you lose insurance coverage, you set yourself up to maintain your results through lifestyle alone. On the surface, that sounds logical. It sounds reasonable. It sounds responsible. It's what a lot of people, including some healthcare providers, generally believe and tell their patients. This study challenges that thinking directly, not with opinions, with randomized controlled trial data. That is not a willpower story. That is not a discipline story. And this is where the conversation about obesity needs to evolve because we are still, as a society, operating under the assumption that if you just try hard enough, if you just eat right and move more, you can override what your body is doing underneath the surface. This study is yet another piece of evidence that for many people living with obesity, it is far more complicated then calories in and calories out. The body fights back. Hormones change. The brain's hunger and satiety signals don't simply reset because you lost weight. The disease of obesity is chronic and progressive, and lifestyle intervention, as powerful and as important as it is often not sufficient on its own to maintain significant weight loss once treatment is stopped. Now, this doesn't mean lifestyle changes don't matter. They absolutely do, and they are a critical part of treatment. But this data suggests we need to stop using lifestyle changes as the justification for eventually getting off the medication, because for most people, that off ramp may not exist the way we thought it did. Okay, let's talk numbers, and I promise to keep it digestible. By week 112, here's where each group landed in terms of total weight loss from their starting point. The full dose group, they were down 21.9% from baseline. Essentially, they kept losing, barely any regain at all, less than half a pound on average from where they were at the randomization. The 5 milligram group, they were down 16.6% from baseline. They did regain some, about 6 kilograms or roughly 13 pounds from their lowest point, but they held on to most of what they lost. And then the placebo group, they were down only 9.9% from baseline. They regained about 12.8 kilograms, nearly 28 pounds from where they were at randomization. But here's the number I really want you to sit with. Among participants who had plateaued, meaning they'd hit their weight loss ceiling, look at how much of their loss each group maintained. The full dose group, 96.5% of their weight loss was preserved, essentially all of it. The 5 milligram group, 67.9% preserved. They kept about 2/3. And then the placebo group, 42.8% preserved their loss. That's less than half. And remember that rescue therapy I mentioned earlier? Here's how many people needed it. 8% of the full dose group, 25% of the 5 milligram group, and a stunning 67% of the placebo group. 2 out of every 3 people who stopped the medication regained enough weight that they had to be put back on the medication. And again, those people were not failing their lifestyle plans. They were actively receiving counseling and support the entire time. Their bodies simply fought back harder than lifestyle intervention alone could counter. I've partnered with Fridays, and if you're uninsured, underinsured, or branded GLP-1s just aren't in the budget for you, Fridays has you covered. They offer compounded GLP-1 options at accessible prices with no membership fees. And that includes your lab work, unlimited provider visits, nutrition coaching, dietitian support, and live workout programs. They also provide access to TRT for all you men out there and powerhouse supplements like Samoralin and NAD+. They even have a meal delivery service for an additional charge. You can use the link in the description of this video and the code RMZ to get a discount on your first order. Now, I want to spend a minute here because this is the part that doesn't get talked about enough when people debate whether to stay on these medications. It's not just about the weight loss. It never was. When participants in the full dose group continued tirzepatide, they maintained significant improvements in blood pressure, triglycerides, HDL cholesterol, blood sugar, and waist circumference. Among people who had prediabetes at the start of the study, 92.7% of the full dose group had achieved normal sugar levels by week 112. The 5 milligram group came in at 84.4%. And the placebo group, 51%. Think about what that means. Nearly half of all people who stopped the medication lost their blood sugar normalization, despite continuing lifestyle support. Their cardiovascular risk markers started deteriorating. Their blood pressure crept back up. Their triglycerides worsened. This is the part of the conversation that goes beyond appearance and beyond the scale. These are markers that predict heart attacks, strokes, and diabetes. And we now have clear evidence that stopping the medication reverses those improvements for a large portion of the patients, even when they're still doing everything else right. This mirrors exactly what we saw in the SURMOUNT-4 trial. When you stop the drug, the biology doesn't stay where you left it. The disease of obesity is chronic and progressive, and without continued treatment, the body tends to drift back towards where it was. That's not a personal failure, that's physiology. Now, here's something I want to flag for you because it matters practically when you're talking to your doctor or dealing with insurance. They'll design a study around what they consider full maintenance doses. That's 5 milligrams, 10 milligrams, and 15 milligrams weekly. In their framework, those are your established treatment doses. The intermediate doses, the 2.5, 7.5, and the 12.5 milligrams, are considered transitional doses. They're the steps you go through on your way up to a full dose, not doses you're meant to stay on long term. And because of that framing, those intermediate doses were never studied as maintenance options in this trial. But here's where I want you to think critically for a second, because I think there's a reasonable clinical deduction to be made here. We now have data showing meaningful benefits at 5 milligrams. We have data showing strong benefits at 10 milligrams and 15 milligrams. So we know that both sides of the 7.5 milligram and both sides of the 12.5 milligram produce real measurable results. It's not a stretch to reason that those intermediate doses are likely doing something meaningful too. We just don't have the randomized controlled trial data to prove it because of the way that the study was designed. The trial simply wasn't built to answer that question. That's an important distinction. The absence of data is not the same thing as evidence of absence. We can't say the intermediate doses don't work for maintenance. We just haven't studied them that way. So here's the practical takeaway. If you're currently on 7.5 milligrams or 12.5 milligrams, those doses are working for you. You're tolerating them well and you're maintaining meaningful results. That is a conversation worth having with your doctor because nothing in this study tells you you must jump to a full dose to get benefit. It just means we don't have the trial data to point to it yet. Now, where it does get complicated is on the insurance side because some insurers are increasingly aligning their coverage policies with how the drug was actually studied. Some will only approve those intermediate doses for about a month, treating them strictly as a stepping stone to a full dose rather than a destination. So if your insurer is pushing back on covering 7.5 milligrams or 12.5 milligrams long term, that's the dynamic at play. It's a coverage argument, not necessarily a clinical one. The bottom line, talk to your doctor about what dose is actually working for you and your body. Understand what your insurance will and won't cover, and don't let anyone pressure you into a dose change that isn't driven by your clinical response. The goal is sustained benefit, and if you're getting that on an intermediate dose, that matters. All right, let's address the question head on. The honest answer from the data is, for most people, yes. Some form of ongoing treatment appears to be necessary to maintain the benefits, but forever doesn't have to mean maximum dose forever. Here's what the study actually gives us. If you can stay on the full dose and tolerate it, that's the strongest option. You keep nearly all your weight loss and your cardiometabolic improvements. If cost, side effects, or personal preference make the full dose difficult, 5 milligram is a legitimate alternative with real data behind it. You'll likely regain some weight, roughly 6 to 7 kilograms on average, but you'll preserve meaningful health benefits and avoid significant regain that comes with stopping entirely. Stopping entirely based on what we've seen across SURMOUNT-4 and SURMOUNT-MAINTAIN leads most people back towards where they started, and it takes the health gains with it. And as we've now established, continuing lifestyle changes alone is not a reliable safety net for most people once the medication stops. The researchers themselves put it plainly, obesity is a chronic progressive disease. We don't tell people with hypertension or high cholesterol to stop their medication once their numbers look good. We don't tell someone managing depression to stop their antidepressant once they feel better. The same logic increasingly applies here. So there it is, the most rigorous look yet at what happens when you try to taper or stop tirzepatide after successful weight loss. The data is clear that continued therapy matters, that dose matters, that the cardiometabolic benefits you've worked for are not permanent if you walk away from treatment, and that lifestyle changes alone, as important as they are not sufficient for most people to maintain their results once the medication is gone. I know that's not the answer everyone wants to hear, and I know there are real barriers, costs, coverage, access, that make long-term treatment genuinely difficult for a lot of people. Those are real conversations worth having with your provider and with your insurer, and possibly even your employer. But what I hope you take away from today is this. If you've regained weight after stopping one of these medications, that is not a character flaw. That is not a failure of effort. That is your biology doing exactly what the research predicted it would do. And you deserve a treatment plan that accounts for that reality. As always, none of this is personal medical advice. Your situation is unique, and these are conversations to have with your provider. But now we can walk into that conversation armed with the actual evidence. If this was helpful, hit that like button, subscribe if you haven't already, and drop your questions or comments down in the comment section. As you know, I read them and I try to reply to all of them. In fact, I do reply to all of them. Until next time, take care of yourselves. This will be linked down in the description of this video. This has been The Weekly Shot.